All right, welcome everyone. Today we're kind of be going over pain science again, more treatment type of ideas, especially integration of manual therapy, etc. You know, you're definitely going to get some new ideas today, but a lot of it's going to be some of the older stuff that we've already talked about, how you measure it, because how you measure it is also how you treat it. But we're going to go into some other different examples as well. So first, how to measure persistent pain, right? Is you can use so many of these things to treat and to get better. So we really need to kind of revisit some of these things. I'm not going to go in exhausting detail by any means, but we do need to touch on some of these because it's going to roll into exactly how you would treat. So again, where do we start? Go multidimensional, slowly going into unidimensional. Unless you truly know what's exactly going on, oftentimes you always need to start multidimensional. From there, looking at the body chart, this is going to become so ingrained with where it's at, how does it flow, does it separate, etc. Central sensitized pain all rolls together, right? So you wouldn't really see too much of a separation of the two. So you really need to get a really good idea of the body chart and how it's progressing and what could lead to what, at least what in the patient's mind can lead to what. Some other things to think about too is while we look at the patient, right, we're going to look at maladaptive movements. Simply what we mean by that is, you have adaptive movements. Generally if you have a true herniated disc, bending is just not that good, does not feel that good, that's adaptive, right? You can't create lumbar flexion. So what do? You limit yourself and you slowly get into that. But with many patients, I would say even to acute patients a lot as well, is what pattern are they doing to protect? Or even in sometimes, if they've moved that way so often, what are they doing to provoke their pain? There's typically a maladaptive movement that often will be occurring that you can point out and start diving into it, right? And, it's true is biomechanically they need to change that pattern, but it's the belief pattern that really has solidified those things. What if you add support? What if you take it away? What if you distract? What if you makes it loaded, unloaded, etc.? And that's exactly how you would treat it, right? You would roll into what we'll talk about later is graded exposure and graded exercise for that. Now, laterality. What do we mean by that? When we're looking into complex, regional pain syndrome or persistent pain, a lot of times because of brain smudging and so things occurring, the body really does not process left versus right really well. You guys will get tons of articles and you'll get some more descriptions about this, but typically this is something that we can measure, and there is pretty good lines of where the error rates and what the accuracy should be, etc. Do multiple trials, and if they have a lateral issue, right, and it is mind-boggling, they can't tell left versus right with their foot, knee, hand, etc. It's something we want to train, and often it's the first thing we want to train before we go into many things, before mirror therapy and all that. Typically, this is seen with graded motor imagery, but it can be done by itself and something often measured. Some ideas, they do have recognized apps that are really fantastic. I have about 4 or 5 of them on my phone that I use, but you can do flashcards. You can have patients go through the magazine, and truly, honestly, it's almost like neglect. When you first see it, you can't believe it's truly occurring. This is the same route with that. So let's try it. I am actually going to do this right now. So all I want you to do, get a pen and paper, pause the video right now, get the pen and paper, and then what I want you to do is create a left column and a right column. And you just simply need to say, is this right or is this left? I'm going to give you about 2 seconds for each one, and you can test yourself. And all these pictures are from the Recognize app. So if you're ready, here we go. All right, how did you do? 5 left, 5 right. If you got less than 80%, do not worry. This is something you would do multiple times to see where someone would be. Oftentimes, the first time can be a little challenging, but after a couple times, they should absolutely get it. All right, so let's do it again, right? Fun. How many times do you get interactive in a asynchronous PowerPoint, right? Abstracted foot. So typically we would start with what's called basic, and then we would move more to what's called abstracted, which is, it's harder to see, but it really takes the brain to focus into, visualize, and it can be really good for kind of sharpening that cortical, re-imaging an area. So if you're ready, again, have a column left, column right, count them out as we go. All right, 3, 2, 1. All right, so how did you do, right? It's challenging. That one especially can be very challenging, all right? Because even just for people that don't have foot pain and everything like that. But it can be a very good thing to do with your patients and gives them an easy way to do an exercise at home. And that's your treatment, is them, grabbing a magazine, using the apps, etc., going over it again and again and again and again. Trying to get above that 80%. After they can, get above 80% in the abstracted category, then you could possibly move on to, if you're doing GMI, you can move on to graded exposure or implicit. You can move on to explicit imagery. But if you're going another route, you can do some other things with them as well. All right. So again, that's how you treat. All right, so again, 2-point discrimination. Think about the noisy neighbors, right? When we have pain, that pain will spread. Our 2-point discrimination will get very much out of whack. So we can measure this. We have measurements. And if it is out of whack, we can actually train it and help people. So here is your norms. I'm going to give you these slides so you guys will have it. And you can use these as kind of a little bit of a guidance. Really good for those patients that are very too hot to handle, that they can barely take any touch. They could take a small pinprick things or pencils, or I even have a little measuring tool that I will use for this sometimes. What you can often tell the patient is, especially with those too hot to handle, it'd be like, hey, I know you can't take us rubbing into this because this area is really, really sensitive. This can help reduce that sensitivity. Right, so you can use many of the metaphors we've kind of already learned for that. So using that, using a tool, making sure you stay above it, and just doing reps upon reps upon reps. I would definitely wouldn't say this should be your only treatment, but it can be one that you can bring into the fold. Localization testing, right? So really cool way that a lot of people, and you might have seen this as well, is patients often can't say, especially with the low back, is where are you touching? It's like you start touching their TL junction. They're like, oh yeah, that's that pain I have deep low down in my back. You're like, right here, like, yeah, that's it. But it's like, well, that's your thoracic spine, right? So you can give a patient a chart and have them kind of looking at it, and you ask them, okay, where am I? Where am I? Where am I? I've seen this work really, really well for knee OA, for patients that have very sensitized knees, patients that have very sensitized back, especially the patients that you touch and they flinch away a little bit. This could be something that's I actually just pulled these offline so you can print them off. And you'll be actually reading a study about how to do this and use these. So how do you treat, right? You can go off the study that I'm going to give you guys. It's just labeled grid. Or you can just, I set a timer for 3 or 5 minutes saying, okay, where am I? Where am I? Where am I? I'm, again, looking for a good percentage of the time. And just challenging that patient to, become aware of their body and where we're at and what does it look like and everything. All right, some other things, brush strokes, algometers, cold hypersensitivity, temporal summation. These are other things that you can use, especially if you get into treating a whole lot of persistent pain that can make things objective. Something like whiplash, cold hypersensitivity is on up there. Temporal summation, pressing into someone, backing out, pressing again, backing out, pressing in, backing out. Does that ramp up their pain? Right? That's another test that you can do to people. So there's a whole lot of ways that we can tell and treat persistent pain and measure persistent pain. But a lot of times, you just do need some of the tools to do it. Now, algometer is a phenomenal way to measure things. My biggest suggestion on this, especially how you treat it, if you do get one, look on eBay and just make sure you have the right head. That's actually how mine saves you a couple $100. But also, you can mark on the body when things occur. Like, for instance, if you have a marker, I'm testing lateral epicondylalgia. Mark exactly where you did that. And all I do is I mark, okay, I did it here, do the pressure algometer. You stop the moment that they start feeling pain, and then do your things and then redo it. Really good way to test the sensitivity of the area, but make sure you mark that spot, or honestly, it will drive you crazy because things can move all over the place. Awesome. Some other things that, I think it's beyond the scope of this class to go into. I'm a gigantic component of neurodynamics. I think that is far underutilized in so many of our, just practice, right? And oftentimes there's issues, we just don't test it right, etc. With patients with persistent pain, we do want to palpate, we do want to measure these things, right? So what do I mean by that? Well, this is your general areas that you will feel, your median nerve. Here's where you can do the palpations, right? Again, I'm not going to go through all these. You've got the slides, but if you have a patient with persistent pain or any kind of nerve, you need to be palpated in these spots, looking for, is it just hypersensitive? Does it reproduce their pain? Same thing, radial nerve, right? Typical spots that you can palpate to see the hypersensitivity of the area. Ulnar nerve, same thing. We know these very well, especially if you accidentally ever banged your elbow. Again, another area where you can palpate and see is there hypersensitivity in the area. So how do we treat that, right? You can do your neurodynamics, which is awesome. I've got a slide here coming up in a second that's really good about grading. You can needle. Awesome way, you can cup. If you have some people with some pretty hypersensitivity areas, especially like say you have the biceps, right there, cup that area, have them do glides right over that significant tender spot. What's it doing? I don't know, but I would say anecdotally it can work very, very well. But what about dosing, right? How do we dose it? How do we treat it? All those things. This is a very good slide. This was created out of Adrian Lowe's work. And this is a very good guidance to your patients of what to feel, what not to feel, how to deal with it, etc. From a irritability standpoint, if you are dealing with nerves, it is always moderate, at least moderate irritable till proven otherwise. So keep that in mind when you're doing it. Start easy and build slowly, of course. All right, so where do we go, right? Where do we look for, etc.? Of course, you assess the readiness to change if you're targeting certain behaviors of patients, right? We haven't talked about that. That's going to come in the next module. But we do need to assess that readiness to change for some of those patients. We have that educate, which is what you guys really learned this previous model. And then treat, but using that education that we did to guide our treatment, right? Readiness to change. I know you guys have already seen this before, but again, here is the kind of the model for patients a lot. Again, we'll get into this in the following module. Some other ways to rule it. Look, we really need to go into this with patients, especially if we're going to be pushing them into an area they're uncomfortable with, etc. Other ways, what to look for, what the benefits. This is out of like a diet nutrition thing that's pretty good. But again, I know I've seen this before. We'll go much more detailed next module. Always remember, pain science is caught, not taught, right? Your interventions and your activities have to reinforce your education. You can't educate and leave it there. And most importantly, you can't do an intervention that undoes your education, right? So if you're explaining sometimes and you're explaining about sensitivity and everything, but then people say, well, what's wrong with my neck? Well, what I'm working is 3-4 is not necessarily gliding up on this side. It won't close down, so therefore blah, blah, blah. You just undid your education there, right? And again, I don't yak anyone's yum. If that's how you explain, kudos. But if you're explaining about sensitivity and you're explaining it's more about sensitivity than a biomechanical or a pathoanatomical, you can't then explain your manual therapy that way. You'd be better off with, honestly, a lot of times that's stuff I say to my patients is they're like, what's going on there? It's like, well, we talked about this sensitivity. It's going to kind of stiffen some things up. So I'm just going here and loosening it up for you. I'm just calming stuff down so then we can build stuff up, and then I can expand upon that if I need to. Always remember, the more complex the pain is, the more comprehensive the treatment needs to be, especially bringing in other outside providers. And the more chronic it is, the more active the treatment must be, right? And what do we mean though, that active, etc.? Well, what we know is PNE by itself will not just get the job done. It needs to be PNE plus. So what have we seen works with persistent pain? Here's all your things. For those that are funny, guess what? Humor works with persistent pain. Breathing works with persistent pain. Nutrition works with persistent pain. These things help, right? We're going to be going into a lot of these, the following module. This is more about our intervention, hands-on, etc. But these are things that you can keep in mind that can work very powerful for your patients. Some other things, graded exercise. Here's a little bit of how you want to go back to doing that, setting a goal, doing some of that. With this, oftentimes I'll have a quota. You need that number for that patient, and then you'll say, okay, start easy, build slowly. To be honest, I recently tweaked my back very bad, woke up shifted, horrible neurodynamic issues going on right now. We think it's due to a tether in my thoracic spine, believe it or not. And so our graded exercise right now is, because I try to be very un-PT, I just like, let me be the patient to my PT, is we're doing graded exercises. Our goal is to get to 10 thoracic slumps a day. We're breaking it up and we're trying to get that to a day and then eventually get there. And I'll be honest, it's 3 weeks now and I've gotten up to 5 with each leg. And if I do more than that, it really starts to flare up. But I have to do it. I have to start getting some motion in there. And, that increasing the quota and giving an aim really helps me, even with all the pain sign stuff I know. Whew, man, when you get that pain across that back, it's not going to help you, right? So looking at things and building up to it and having a goal can be very beneficial to these patients, even if they can't do anything. Split it up multiple times a day, use your SMART goals, and you will see a huge difference with this. So what do we mean by, so that's graded exercise, right? You're having a quota building up. Graded exercise and graded exposure are two totally different things. Each of them can be different, right? So for me, I do have a mechanical issue, and I will be honest, deathly afraid of that thing flaring up too. Graded exposure doesn't really help me, right? Now it can help my maladaptive movements that I've built up, but it's not going to help me per se because it's still a mechanical issue that I can't do. For some of your patients that, like bending is a perfect example, that are fearful, so aka what I will most likely be like in about 2 months, is, okay, let's start supine. Let's start side lying, right? And then bring it to the attention, hey, I know bending really, really bothers you, but here's the awesome thing. You know how you can bring your knees to your chest and it actually feels good? That's the same motion that you do when you're bending over much, on it, which is awesome because that means that we just got to increase your tolerance to it. It's not like that your body can't do it. That's a whole nother thing. So that's why I think that this is about that sensitivity we talked about. Looking at patients, can you support them? Can you unweight bear them? Can you get specific versus unspecific, right? True bending versus, okay, I want you, doing some activities like roll the ball out, make it contextual. Me bending over, might be very stressful if all my kids are around, but not at all if they aren't. Or here's my favorite, is doing things in the gym, but then not being able to do it at all outside of the gym. It's contextual, right? So maybe that's something that you need to work on with your patients. But again, graded exposure and graded exercise, two totally different things, and you really just have to use rationale for what you want. Both of them are good. It's just different to each patient. Okay, finally. So your assignment this week will go into this, right? Your manual therapy techniques. Um, when when you're doing these things, you can just straight up, you don't have to do all of them. You can just change how you described it to patients. Talked about like, calming things down, reducing sensitivity. You can do it that way. I'm not going to force you guys or, hold a gun to your head and say, do localization or 2-point discrimination. Just going to challenge you to kind of open up your toolbox, aka your pain science toolbox, and bring some of these in. So the 2-point discrimination might be hard for you to set up, but it's pretty easy and sometimes fun for patients. Localization, really good. I've seen, again, pure anecdotal. I've actually seen this really, really work well with PANS and serine bursitis. I've had like 3 patients that have done very well with that weren't getting better conservatively because for some reason that thing lingers sometimes, which is just weird. Neurodynamics, another really good one that you can do. And then finally, descriptive manual therapy. So this is another study you will see with the straight leg raise, is they went in and basically asked the patient, okay, do you think I'm, at the top of your spine or the bottom of your spine? Okay, am I superficial or deep? Do you feel this going this way? Is bringing that attention to your patient about what you're doing, have them verbalize. So it's making something that's generally passive, like UPAs, and turning it into active. Lo and behold, maybe that's why fellows are actually a little bit better manual therapy, because we're constantly assessing that and bringing their patients' attention to it as well, right? And then solidifying it by a test, treat, retest. So that could be your description, instead of just sitting there working on a patient, start asking them to describe it. How does that feel? Oh, that feels good. Awesome. Let's open that up a little bit. Oh man, you're getting some motion in there. Do you feel that going deep? Do you feel that me going deep into there? Or does it feel superficial to you? Those little things you can describe, but then test, treat, retest it and see how it does. There is indications for no manual therapy, right? Obviously, if you always do something, you're always going to miss something. This is the thing that's kind of always killed me, because I grew up in, not grew up, I was trained in, you do always manual therapy, and the only day that you don't is the day they don't show up, right? Even on discharge day, you're going to do 2 units of manual therapy, because that doesn't make sense, but you need to, all right? There is indications you don't. If there's safety issues or red flags, obviously. If they're centrally sensitized, I would put a precaution here. You might need to do it to get a buy-in a little bit, but generally you have to go maladaptive beliefs first and then go there. High psychosocial risk patients, you want to be very cautious with. Very addicted to manual therapy. We all had those patients that are addicted to it. Needling really fits into this category a lot. To me is like, does the needling then allow them to go do something? There's a lot of questions you want to ask about that. Do you take away their locus of control with it, right? Do you do a biomedical reinforcement? Are you reinforcing maladaptive beliefs with your manual therapy, but not with your education? And then finally, safety with touch, and nocebo. So a lot of patients can have that nocebo effect. For patients that you think about, like, how did I flare that person up? I barely did anything. Those are the ones that this category fits, honestly. So finally, right, this really kind of goes into next week. And not next week, next module. But here is the truth, right? With these patients and what you're doing and the changes you're making, you can't pour from an empty cup, right? So with this, you have to admit our limitations, right? That we have to admit our own struggles. We have to admit where this is very hard to treat these patients, and I can't give a magical thing. All I can do is give you tools that allows you to hopefully plant seeds with them. If you pour too much of yourself out, though, for patients, you won't have anything left in the tank. So my guidance is, how well did you eat? Now, not in the sense of a patient getting better as the litmus test, but, did you give your all for that patient? Did they feel, lack of a better word, love? Did they feel that grace and truth when they came through the door? Those are the measurements you should do. If you're constantly with these patients that that outcome is the difference of you feeling like you did good or not, or if, again, that litmus test is them getting better or not. With these patients, you will be this cup and you will be burned out very, very quickly. So finally, I do want to mention this because I do truly believe that this, treating these patients can truly just wear down on us. There's so many things to talk about burnout. My area of research is in burnout, so that's why I'm probably capping this on. What is burnout? Because it's not you'll hear some people, well, it's become like a catch-all term. It's not all at all. Burnout is actually extremely easily defined. Do you feel disengaged, right? Are you exhausted? Boom, 2 factors of burnout, right? And to that point of disengaging between your patients, constantly exhausted, that's leading to changes in your life for the worst, ultimately. So many factors that can be applied at that, and there's different tools that you could do for yourself. Other mindsets that can help is growth mindset, emotional intelligence. Everyone is unique, right, for themselves. But truthfully, if you do want to look at research and what is the number one thing that determines one's happiness, it's control over their time. And why is that important for fellows in training is you will realize that not everyone, but that probably is going to be your one sticking point, because you want to do things for these patients, but it's very hard to do when you have 3 patients, waiting on you, and you have this, and you're dealing with so much stress, and you're dealing with so many things going on in the clinic that you truly can't focus on what you want to do. So with these patients, create that control over time, create that time to work with them, plan out once a week at 1 person per hour, right? With this patient, I know that's faux pas, but truly with them, you might need to do that. Now, you might not always need to do that, but sometimes you might. So I would really try to suggest that for you guys. Awesome. Thank you so much. Again, this is a hard lecture to give because, typically I need to be showing, we need to be practicing, etc. My assignment for you is just to be curious with it, to explore it, to try it, to have fun with it, dare I say, right? And I think you guys will get a whole lot of benefit of it. But anyways, thank you so much, and I'm looking forward to you guys this week.